During peripheral VA ECMO, if the return, arterial, cannula is advanced too far into the aortic arch, what is a potential risk? A. Localized cooling of the brain. B. Selective hyperperfusion of the right subclavian artery. C. Increased risk of cerebral embolic events or sandblasting the aortic wall. D. Improved coronary artery perfusion. Answer: C. Increased risk of cerebral embolic events or sandblasting the aortic wall. Explanation: high-velocity flow exiting the cannula can cause turbulent jet flow, potentially dislodging plaques in the arch or causing endothelial damage. Which finding on a transthoracic echocardiogram, TTE, suggests that a patient on VA ECMO is not ready for weaning? A. Aortic valve opening with every beat. B. Left ventricular VTI, velocity time integral, of 15 centimeters. C. Sustained smoke or spontaneous echo contrast in the left ventricle. D. Map of 75 mm of mercury on low-dose norepinephrine. Answer: C. Sustained smoke or spontaneous echo contrast in the left ventricle. Explanation: smoke in the LV indicates blood stasis. If the heart cannot eject blood effectively even with ECMO assistance, weaning will likely lead to acute thrombosis or pump failure. What is VVA ECMO, hybrid ECMO, and when is it typically used? A. It's used when a patient has isolated renal failure. B. It's used when a patient on VV ECMO develops cardiogenic shock. C. It's used to speed up the weaning process in pediatric patients. D. It's a method for cooling the patient during surgery. Answer: B. It's used when a patient on VV ECMO develops cardiogenic shock. Explanation: hybrid VVA uses 2 drainage cannulae, venous, and 1 return, arterial, or 1 drainage and 2 returns, 1 venous, 1 arterial. It provides both high-level oxygenation and circulatory support. Why is negative pressure, suction, monitored in the venous drainage line? A. To ensure the pump is spinning fast enough. B. To prevent hemolysis, destruction of red blood cells. C. To monitor for air emboli. D. To measure the patient's central venous pressure, CVP. Answer: B. To prevent hemolysis, destruction of red blood cells. Explanation: excessive negative pressure, usually greater than -60 to -80 mm of mercury, can cause red blood cells to rupture, hemolysis, and indicates that the drainage cannula is too small or obstructed. During a VV-ECMO weaning trial, you turn the sweep gas to 0 liters per minute. The SAW-2 stays at 95%, but the patient becomes tachypneic with a respiratory rate of 35. What is the most likely cause? A. Oxygenation failure. B. Failure of CO2 clearance, ventilatory failure. C. Anxiety from the procedure. D. Pulmonary embolism. Answer: B. Failure of CO2 clearance, ventilatory failure. Explanation: many patients can oxygenate well enough to keep saturations up, but their lungs are too stiff or tired to blow off CO2. The resulting respiratory acidosis drives the tachypnea. Which cannulation site is associated with the highest risk of stroke during VA ECMO? A. Femoral artery. B. Axillary artery. C. Carotid artery. D. Dorsalis pedis. Answer: C. Carotid artery. Explanation: while the carotid is used in some neonatal cases, it carries the highest risk of embolic or hypoperfusion-related stroke in adults compared to femoral or axillary access. Differential hypoxia is a risk during weaning from which type of ECMO? A. VV ECMO. B. Peripheral VA ECMO. C. Central VA ECMO. D. VVA ECMO. Answer: B. Peripheral VA ECMO. Explanation: as the heart recovers in peripheral VA ECMO, it begins pumping deoxygenated blood from the lungs to the brain, while the ECMO machine sends oxygenated blood to the legs, north-south syndrome. What is the role of a pigtail catheter in the left ventricle, LV, during VA ECMO? A. To deliver medications directly to the heart. B. To vent the LV and prevent distension/pulmonary edema. C. To measure the cardiac output precisely. D. To act as a backup drainage cannula. Answer: B. To vent the LV and prevent distension/pulmonary edema. Explanation: in patients with severe LV failure, the heart cannot open the aortic valve against the ECMO pressure. An LV vent, pigtail or impella, removes this blood to prevent the heart from overstretching. During decannulation of a surgically placed axillary cannula, what is the primary surgical concern? A. Preventing a pneumothorax. B. Ensuring the brachial plexus is not damaged during the closure. C. Monitoring for a liver laceration. D. Managing the patient's temperature. Answer: B. Ensuring the brachial plexus is not damaged during the closure. Explanation: the axillary artery is in close proximity to the brachial plexus. Retraction or suturing in this area must be extremely precise to avoid permanent nerve damage. In the decannulation phase of VV-ECMO, what is the purse string suture used for? A. To tie the cannula to the bed frame. B. To provide a quick seal of the venous site once the cannula is pulled. C. To measure the depth of the cannula. D. To attach the oxygenator to the pump. Answer: B. To provide a quick seal of the venous site once the cannula is pulled. Explanation: a purse string suture is placed around the insertion site before the cannula is removed. When the cannula is pulled, the suture is tightened to provide immediate hemostasis.